Hello everyone. I'm Dr. Konda Chaitanya. I'm from Karimnagar, endocrinologist. Today we are going to discuss a case study regarding which having a high risk of heart failure. What is the newer modalities of treatment which is available now, and what can we do better for our patients? Mr. Kamal is a college professor. It's a case-based discussion where the 58-year-old female with the type 2 diabetes since 4 years and also has routine checkup, and she is now complaining of a generalized weakness. He had a history of MI, which 1 year ago, and went through to PTCA. Now the family history also, his father had a similar event where he has done a CABG 5 years ago. Now coming to his clinical characteristics like BMI, it's around 29.7, suggestive of obesity, which includes blood pressure, which is on the higher side of 146 over 86, and A1C is not under proper control, where it is around 8.4. LDL-C, which is suggestive of 75 mg per deciliter, and HDL-C is 37, triglycerides is 156, and total cholesterol is 168. So, and GFR, which is around 65 ml per minute. So, this is also at somewhat higher risk, and urine albumin creatine ratio suggestive of an albuminuria of 300 mg per gram. Microalbuminuria is present. So, Tudigo, which is suggestive of dilated LA and RA, and medication which is on with metformin 1 gram along with Limfred 4 mg, the maximum dose they have started using. Losartan 50 mg OD and atorvastatin 40 and amlo 5 and chlorothiazide it's 15 mg and metoprolol around 50 mg daily, and along with aspirin he has started. So she is using almost maximum medicines which is required for her, but still not under control with the A1C, where she also having its poor sedentary lifestyle and continuously having its weight gain, and she does very less physical activity like exercises. But the frustrated about main thing important is that doesn't want to gain weight much beyond this point. So she also sometimes occasionally had hypoglycemic events as well as, so the intermittent episodes of hypoglycemia is present in this case. Important challenges in this patient is in presence of a poorly controlled glycemia along with the intermittent hypoglycemia, and obese individual, and also having hypertension and previous MI and microalbuminuria. So these are the different challenges which has been present to our in case. And what are the risk factors of the patient is very high risk, where a middle-aged woman which is also having some target end organ damage already established with the vascular events, and also having an individualized of A1C target has to be set in this case, and weight gain due to less physical exercise. These are the different risks which has been present in this case. As we know that type 2 diabetes mellitus, which is a chronic disease with a complexity in management, where it is related to this hyperglycemia and glycemic control over the time. And whereas type 2 diabetes also majorly associated with the CV risk events, particularly along with the diabetes, also this individual had this obesity, arterial hypertension, dyslipidemia, which all in contributes towards the increased thrombogenic status. And also the most of our patients with the diabetes will have the low grade inflammation ongoing and oxidative stress due to different reasons. So all this will contribute towards one path towards the atherosclerotic heart diseases, so which will lead to MI or stroke or PAD. So as we know, almost our 50% of the patients are dying because of this cardiovascular disease, particularly from the coronary artery disease. So if you are coming to the what could be best we can do in our treatment part to reduce these CV complications, in spite of our management at a maximum level, also still we are getting these cases. So we can still, there is a scope of reducing these CV events to certain extent. So what could be we can do? And also another important thing, CKD also which is becoming a major concern in a patients, particularly in patients like who are already had a heart failure. So this is a complex of management of such cases, so which has been present in day-to-day practices. So both at least part due to the reduction in the premature death among these patients. So if the patient, if we see CKD with heart failure, the complexity in management in such cases is becoming a very difficult task. But where we can go with the newer drugs to challenge these particular conditions, where we are going to do a better drugs if you're choosing it in a conscious way. So from 2019 ADA, which is also started recommending where you have to start using of CV protection agent on addition to this OADs if there is an established cardiovascular disease, in particularly with the type 2 diabetes individuals. So it is one of the important aspect of been changing, which has been coming from ADA from 2019. So, what would made this area to change these concepts regarding this cardiovascular disease risk management? So in 2015, as we know that EMPA-REG outcome is a major outcome study regarding the empagliflozin, which has been came out and which has been showed significantly reduce the heart failure risk by 35%. So that is the landmark trial which has been important in the last decade, where we are seeing this is the, showing a significant improvement in the diabetic management part, and also the drug which is not only acting over in particularly which is related to the decreasing in the CV outcome, also reducing the hospitalization for the heart failure, which is also definitely decreasing in most of our cases. Where we, if you go starting of these SGLT2 inhibitors might prevent heart failure in most of our diabetics, even non-diabetic patients also, which has been published with this empagliflozin from the Emperor, where with or without diabetes, which is also showing the major benefit with hospitalization for the heart failure. Whereas coming with the EMPA heart cardiolink study demonstrated that empagliflozin could produce a reversible cardiac remodeling in type 2 diabetes stable coronary artery disease. So this is another important aspect of these new drugs. So these are the multiple effects which has been showing with this empagliflozin, where it is also having a remodeling effect over the cardiac tissues. In sub-analysis from the EMPA-REG study, if we go with about regarding the nephropathic changes, which is also reduced the new onset of nephropathy by around 39% with on top of RAS blockers. So it's a maximum treatment what we could offer in the recent times. If it is adding on EMPA, which is reducing around 39%. The both CV and renal benefits has to, which is maintaining particularly at a par, and it is also improving independent of EGFR even with the progressive EGFR declines. So if you're coming to the unique mechanism of action, where SGLT2 not only having a glycemic control to a certain extent, I say moderate control, but it is also having its pleiotropic effects like reduction in the blood pressure and also in the natriuresis and body weight changes. So these are the multiple effects which could conferring the protection over the CV and renal risk, particularly in type 2 diabetes. And another drug where we are going to discuss is the linagliptin. It's a unique drug where in the recent times, which is mainly metabolized to the hepatobiliary route, which doesn't require any renal elimination. So this is the drug where we can easily can be used in CKD. Particularly from the study from the Carmelina, this is also got a cardiovascular study after sitagliptin, where it is showing the CV outcome study from confirmed linagliptin to reduce even not for the CV events. It's a neutral, where it is also showing the progression of albuminuria by 14% to reduce the risk for progression of albuminuria. So the combination of these drugs, like if you are targeting the CV safety and also having a CV neutral or CV safe drugs like linagliptin, where we can in combination where it is a suitable target, particularly in the patient had a poor glycemic control, also having a hypoglycemia. So at the same time, we have to control the better glycemic control, and at the same time, we have to reduce the hypoglycemia. So these are the two independent drugs which you can be combined. The newer drug, which combination which has been coming with EMPA with linagliptin in a different strengths like 10 mg or with 5 mg, 25 and 5 mg, which has been coming now. So one of the another important aspect of this combination is where once the studies which is showing where the genital infections also coming down when in used in a combination of SGLT2 with the DPP4 inhibitors, where the number of genital mycotic infections or genital infections has been coming down. So this is another positive effect where we can show with this both drug combination. So additionally, it is also reduce the pill burden to certain extent and optimizing the benefits towards the treatment of diabetes, where it will reduce the CV safety and improving the renal part, and also having the generalized mycotic, this genital infection, which is also coming down. So these are the multiple benefits which can be offered with these two combination. We have learned about the new two drug combination, how we can use better in our patients, where is the better ideal situation where we can apply these medicines towards our population, where we can get the better treatment options. So coming to the end of the session, I want to thanks Lupin for giving this opportunity to me to have a podcast series, and I think I'm done somewhat better with this knowledge improvement in our general physician doctors to have this about improving their knowledge. Thank you very much, Lupin.